Hello there. A warm welcome to everybody joining us for this session, the afternoon session for the first day of our 7th annual ISNTD Festival. Many thanks for joining us. It's been a very interesting morning. We had some superb insights at the beginning from the WHO's Head of Communications, Gabby Stern, and moved into looking at films from a community perspective with the MMV, Medicines for Malaria Ventures, the World Mosquito Program, amongst others. A very interesting session on the use of AI in terms of predictive capacity building, but for an avatar that can be used in dengue settings by Takeda Pharma. Valneva talked about the chikungunya disease awareness approaches and the DNDi about leishmaniasis. There's currently a workshop on as well in a subsequent stream in terms of how to get an idea translated into video, i.e. production values. But we wanted to have a session on data. A lot of the issues that were coming up in some of the disease settings were the lack of, obviously for an NTD, there is a lack of a working diagnostic, but even in settings where there are diagnostics, it's just starting to pick up. That coupled with enhanced disease surveillance I say post-COVID, but because of COVID, everybody, governments included, are looking at enhanced disease surveillance as part of their national program. And so everybody's expecting a deluge of data to start appearing, right? Whether that's from these disease surveillance sentinel sites or indeed from citizen science approaches using apps or apps themselves. So we wanted to have this as a session that looks at the use of data and in particular apps and other kind of approaches in that. So I'm absolutely delighted to have in this session, we've got the WHO's Dr. Jose Antonio Ruiz Postigo looking at the improvement of the diagnostic that they've got, an app they've got for skin NTDs, an app that looks at a wide array of skin-based NTDs and how that's improving the kind of landscape of understanding of those diseases from a surveillance perspective. Also then looking at treatment and improved diagnosis for Chagas from the DNDi, Dr. Colin Forsyth. And then we've also got an interesting, very interesting mentoring and app kind of, how to put it, digital tools and the kind of management of a kind of community-based approach to entity management from the company Dimagi. We have Delphine Pedeboy from there, and also the head of the innovations, Dr. Sarvesh Tewari, who are joining us from Cape Town. So thank you for that. Ending the session, we're going to have Professor Joacim Rocklöv from the Heidelberg University's Institute of Global Health, looking at a kind of predictive capacity that can be put onto, or that kind of approach, a lens that can be put onto all of these massive data streams that are going to start, anticipated to start being generated from across the world. What's the role of predictive capacity in that? And so I think that's enough from me, and I think we'll move to the first speaker. We're just waiting for Dr. Postigo to join us from WHO. I know they've got a big press release thing going on themselves, so there might be a little bit of a delay there. So we've probably just changed the running order a bit, and we'll start with the improving the diagnosis and treatment of Chagas diseases with the iChagas app, which is on our showcase as well, from Dr. Colin Forsyth, DNDi, the States. So Colin, lovely to see you again after many years. And I'm going to hand the floor over to you. If I could ask the other speakers just to minimize, or rather just turn the video off in the box at the top and their microphones off. Thank you very much, and I'll hand the floor over to you, Colin.
Thank you, Cameron, and thanks to ISNTD for the invitation and the opportunity to be here today. My name is Colin. I'm with the Drugs for Neglected Diseases Initiative, or DNDi, and I'm going to talk today about an innovation to improve access to Chagas disease, the iChagas app. So why did we develop an app for Chagas disease? Well, just briefly to give some background, Chagas disease is a neglected public health challenge affecting around 6 million people worldwide, but mostly in Latin America. And because the disease has a long asymptomatic period where most people do not realize that they have the infection, and because it primarily affects people who are in conditions of socioeconomic vulnerability, who have precarious access to healthcare, few people with the infection have been able to access testing and treatment. And one of the main barriers that we face is low awareness among healthcare personnel who are serving the population in need. So the iChagas app was developed to address that barrier by helping to raise awareness of Chagas disease among healthcare providers. And a team of around 20 multidisciplinary experts, the majority in Latin America and some from Spain, worked to develop the content for the app from 2020 to 2021. We also worked with a Colombian development firm called Conectados. And the app was launched in Android at the end of 2021 and in iOS in early 2022. Right now, the app is available in Spanish only. However, we have translation ongoing into English, and we're also planning to begin Portuguese translation this year. And here I'm just picturing the team of experts who worked to develop the content for the app, again, representing a broad range of discipline. And just to call attention to the bottom left corner, you can see Andrea Marchiol, who manages the projects for improving treatment access for Chagas disease at DNDi. And she's really the person who led the organization of the creation of the app. She is traveling in Colombia today, so I couldn't be here to do the presentation. And also on the previous slide, they're not pictured, but I just wanted to say a big thank you to the two students who've been helping us with the Spanish translation, Caden and Lucas, who are based in New York. So the iChagas app was created to be available in Android and Apple. Just to note, currently it's available in Android, and because of some changes to the server, we're making some updates to the iOS version, so it should be back available in iOS pretty soon. The app was designed to be as simple as possible for healthcare providers to use. It's user-friendly, it's easy to connect and update, and it has the capability of being used offline. And this was important because a lot of the communities where healthcare providers need to go to help people with Chagas disease might be in remote areas without internet connection. It has low technical demands, so there's no videos or large files on the app, but there are images and graphics and maps. And it's open access, it's free to download and to use. So the app is meant to be an educational tool that has a vast range of information about Chagas disease, ranging from epidemiology, disease transmission and progression, the social context of the disease, information about testing, treatment, the complications that arise in the advanced chronic phase, and monitoring for the disease. So it's meant to be an informational tool. It's not a tool for medical decision-making or data collection or interaction with healthcare providers. And the app now contains 14 modules and 10 self-tests. And this graphic here just shows all of the different modules that you can progress through in the app. starting with the basic epidemiology, moving into transmission, and so forth into the later stages of the disease. So far, this information is from November of last year. At that point, the app had been downloaded by over 500 healthcare professionals in 23 different countries. Now that number is around 560. And you can see on the map, the countries where the app has been downloaded are countries, are countries where Chagas disease is a major public health problem. And the country where it's been downloaded the most is Colombia, picture there in the darker shade of red. And this makes sense just because we have an active collaborative project with the Ministry of Health and other partners in Colombia to improve access to treatment for Chagas disease. And so really we've been working on the ground in Colombia and have been able to get the word out more about the app. But the ambition is for this to be a tool that's used globally, and thus we have an ongoing translation into English and Portuguese. This graphic just shows the professional profile of the people who have downloaded the app. And as you can see, the three biggest categories are doctors, laboratory personnel, and nurses. So that really tells us that the app is being used by people who are working in healthcare and public health. 33 of the users of the app have completed a survey about how the app is working for them. And 100% said that they would recommend the app to a colleague. And over 90% of them indicated that the app had helped them resolve a specific question on Chagas disease. So in conclusion, low awareness of Chagas disease among healthcare providers serving at-risk populations is one of the main barriers to scaling up testing and treatment for Chagas disease. And so the iChagas app is a tool that's meant to complement health system capacity strengthening efforts. And it's important to point out that this should include a broad range of activities, including the development of other information, education, and communication tools targeted at healthcare providers, as well as ongoing virtual and in-person training. And all of these are activities which are conducted through our access projects for Chagas disease, along with our partners. And strengthening healthcare provider education, starting from medical school and going into ongoing training for healthcare personnel in Chagas disease remains a key need and a key piece of the puzzle to starting to scale up access to treatment for this neglected disease. This includes my portion of the presentation, but I would like to now thank everybody who has been listening and who is involved in the creation of the app. And we have a short video to share which gives a little more background on the app. Thank you.
Hola, bienvenidos a la aplicación iChagas de la DNDi, una aplicación para dispositivos móviles con información actualizada sobre la enfermedad de Chagas, diseñada para apoyar al personal de salud de una manera sencilla y didáctica. Gratis, de fácil acceso, la aplicación iChagas es compatible con los sistemas Android y iOS y se puede utilizar incluso cuando no está conectada a la Internet. La enfermedad de Chagas es silenciosa y por eso muchas personas infectadas desconocen su condición. La falta de información sobre la enfermedad entre los profesionales de la salud constituye una barrera importante para el acceso al diagnóstico y tratamiento oportuno de la enfermedad. Actualmente, menos del 10% de las personas con Chagas en las Américas son diagnosticadas y solo alrededor del 1% recibe tratamiento antiparasitario específico, lo que convierte al Chagas en un problema de salud pública. Por eso, la DNDi, junto a expertos en el tema de la salud de países endémicos, desarrolló iChagas, una herramienta para compartir y difundir conocimiento. La aplicación cuenta con módulos en los que es posible conocer las características de la enfermedad, sus manifestaciones clínicas y cómo se diagnostica y trata. También hay datos sobre prevención, asociaciones de pacientes, lecturas de electrocardiograma, mapas, indicadores demográficos y mucho más. La aplicación también incluye acciones de políticas públicas regionales, nacionales e internacionales, así como lineamientos, consensos y guías de atención de diferentes países. También es posible consultar las resoluciones de la OPS, OMS y de otras organizaciones de salud. Todo esto disponible estés donde estés. La información científica es nuestro mayor aliado. Es por eso que la DNDi, una organización de investigación sin fines de lucro, que desarrolla nuevos tratamientos para poblaciones desatendidas, se alía con las nuevas tecnologías y busca brindarle a usted, profesional de la salud, toda la información disponible para la atención de las personas afectadas por la enfermedad de Chagas. Este es el compromiso de la DNDi, llevar la mejor ciencia a los más desatendidos.
Brilliant. Thank you very, very much for that, Colin. Superb. Very interesting, this low awareness and how these apps can move not just disease awareness. Often people think of disease awareness as a static posters or, that kind of, but towards a call to action. And I wonder what the next stages of evolution of these apps are as they embed inside communities and are used in communities, what those call to actions will be. Will it just be the community? Would it be the doctors? How is that going to evolve? It's going to be very interesting to see that. I'm sure some of the questions that come up will reflect that as well. So thank you very, very much. The video we've also placed on our showcase as well, and the app itself. It's in the app section on the showcase. So I'd just like to say thank you very, very much for that, and great to see so much progress. I remember we were discussing this in early days when we met in person in Washington in 2017, right? And that's amazing. So thank you for that a lot. And I'm sure we'll come together at the end for the Q&A, but thank you very much for that. That moves us, we just changed the running order slightly, but we're going to go back to the original speaker, which is Dr. Jose Antonio Ruiz Postigo from the World Health Organization, who is here. He's talking about the Skin NTDs app that they have. Dr. Postigo, thank you very much for joining us.
Thank you, and thank you for this invitation to give me a chance to talk on behalf of the Skin NTDs team in WHO Geneva. I'm Jose Antonio Ruiz Postigo, a medical officer in WHO headquarters. Back in 2018, we published a book, a training guide for frontline health workers. It was published as a hard copy, as PDF, in English, French, Portuguese, and Spanish. The link is there, and very soon we realized that it will be impossible to print enough copies to disseminate the message and to share it across all those who are in need. So we decided to translate this guide, and especially the algorithms, into a mobile app, which is now available as what we call version 2. It's available in the same 4 languages, French, Portuguese, Spanish, and English. It's free of charge in Android and iOS. It can also function offline. And it has something that the book does not have, which is an algorithm that can filter the information by the country of origin. That means that if we are in Tunisia, then when we try to diagnose a disease or a condition, it will only show those conditions that are endemic in that country, or if we know the place where the patient comes from. But later on, we also acknowledge that skin NTDs, in fact, are a very small fraction of the conditions that any health worker will find in the day-to-day. In fact, it will be between 0 to 10% of what is found in the normal consultation. That is why we signed an agreement with the NGO Until No Leprosy Remains, before the Netherlands leprosy relief, so that we could add common skin diseases. So we have added that. Here you have a copy-paste of the skin app of colleagues in the Netherlands. Here is the WHO app, where you just select the part of the body, you select one or several signs or symptoms, and then the application will give you several diagnoses, possibilities, and if you don't know what those diseases are about, you click and you find the information. And of course, because it has only few diseases, it always says that it may be another condition. So the common skin conditions are listed here in this screen. They are now 24 because in March, a few days ago, we added folliculitis, keloid, noma, and urticaria. But last year, we wanted to embrace new technologies. So in collaboration with Universal Doctor, we incorporated a component of artificial intelligence that we have now as a beta version, both in the phone, in the mobile app, or as a desktop. And here you have an example of a couple of photos that we received a few days ago. You upload them, and then the classifier will tell you which of the 5 diseases that we have currently in the artificial intelligence algorithm it could be. So the first photo is a Buruli ulcer child, a patient affected by Buruli ulcer in Australia. So the app, despite it show low confidence, it identified it. And then the other one is a patient affected by leprosy in Gabon. And the classifier say that with high confidence, it is leprosy. One of the main challenges to build an algorithm for artificial intelligence is to have enough photos to train the machine. That's why last November, WHO created a network, a global network, to build a global photograph database and then conduct field assessments to see if the tool is really useful for colleagues in the field. But in between, we also tested the version of the app that does not have the artificial intelligence component. We did an assessment in Ghana and Kenya, and I'm going to show a summary of the results that we got. This was a work done by the Open University of Catalonia in Barcelona. It was a cross-sectional study. I want to emphasize that the tool is also a training tool. It's for educational purposes. It's not a medical device. And we did, we used a version of what we call the mobile application rating scale. It's a standard form to assess apps beyond the number of people who have downloaded or the opinion that they can send you in through the dashboard. So we assess these 6 aspects: engagement, functionality, aesthetics, information, the subjective quality, and app-specific matters. And after that, after this online survey, we also conducted semi-structured interviews. So in total, we had a small sample of 52 colleagues in total from Ghana and Kenya. They were between 36 to 45 years old. They were mainly working in the rural areas, in the public settings. They were not dermatologists. They mentioned that they deal with some skin NTDs like 1 to 3 times per month. They know mobile technology, but they had not been previously trained on this app. They didn't know it. So what are the results after they filled in the Mars questionnaire. So in general, it was considered that is a useful app. It scored 4 out of 5. The best component was the information one here in this green circle, and the poorer was the engagement. Now, if you see for both countries, the purple line is from Ghana, the answers from Ghana, and the blue line is from Kenya. They are very similar, and in both cases, when it comes to engagement, and engagement measures interest, customization, interactivity is where they consider it weaker. But for all the other aspects, it was rated as 4 out of 5. So what we can say about it is that it was considered as a good quality, despite it's a small sample. It helped in increasing knowledge and to diagnose more efficiently. They would recommend it. There was no difference between different variables or aspects. And when we conducted the semi-structured interviews, colleagues, they just confirmed what they had mentioned in the online interview, and they highlighted that notification and the aesthetics should be improved in other versions. So what are the challenges that we found? Well, the first one was that despite we had an ethical committee review and an accepted document from the University of Catalonia, Open University of Catalonia, then countries had to do another ethical review, and in some cases it took very long to go through that process. In other instances it was quite expensive, so it was, even if it was just to test an app and an online questionnaire, it was quite cumbersome to get all the approvals. Then we thought that, again, having just a link sent with an online survey would be a matter of a few days, but it took months to look for people to answer, to remind them to provide the answers. So probably when it comes to the culture of these digital tools, or maybe there is a fatigue of so many emails, so many online requests, that again, it took long to recruit. Local leaders played a role, and until you find the right person that can convince others, you have a barrier there. So people will need someone who is an authority, either a supervisor or someone who is well known in the country, to help with the recruitment. And then for the semi-structured interviews that were synchronous, again, to talk online, not everyone is comfortable with these online discussions. So we felt that if we would have not been in the COVID period, if we would have traveled to Ghana and to Kenya in 1 week, we would have done what we did in several months through the online space. So in conclusion, we consider that the Skin NTDs app of WHO has a good usability, and users consider it acceptable. There are, however, clear recommendations to improve in new versions. We acknowledge that the study is very limited, is a very small sample, and now we want to replicate it with new versions in Ghana with over 600 people. And we need also to improve and to have a proper strategy to disseminate the tool and to implement it. Although so far is in a beta version, the most updated version. So 3 key takeaway messages. We consider that the use of mobile health is likely to improve the management of skin NTDs, especially when it comes to the differential diagnosis. There are very few apps in the field of skin NTDs, especially in Africa, and especially addressing skin NTDs. And no matter what, no matter which tool, it is very important to evaluate so the tool and the acceptance, so that we increase the likelihood of success. So we would like to acknowledge all those who participated in Kenya, in Ghana, and in Barcelona and in Geneva. Thank you very much.
Thank you very, very much, Jose. Wonderful presentation. Lots of food for thought there in terms of the skin NTD apps and its kind of application and future direction as well. So we really appreciate you sharing that with us. We know how busy you are at the WHO as well, so we doubly appreciate that a lot. So thanks. And I'm sure that there are already some questions coming through, which we'll wait to towards the end. And I would say to the lovely audience that's joined us, please do send your questions in. These sessions are for you, to really kind of engage and we'll give you a shout out and everything. But we have our own questions, but it'd be great opportunity to get these people who've given such good amount of time and effort behind their work to be here, and be really interesting to engage with them. Thank you, Manju Rose Matthews, for asking that question. We'll bring that in at the Q&A. We heard a lot then from the two presenters there, from Colin Forsyth and from the DNDi and from Dr. Jose Postigo from the WHO, in terms of apps themselves, improving diagnosis, potentially improving treatment, and this type of kind of approach. What would be really interesting, we felt, was to have somebody who was able to develop apps, offer mentorship, and also had experience of these of NTDs, or kind of had that experience, lived experience of that as well. So a few months ago, we had an ISNTD Connect. It was part of our very successful and much loved Global Schisto Alliance and ISNTD series, the GSA. Big shout out to any of them in terms of Dr. Anouk Guvras and Professor David Rollinson. They have a very interesting series built with them, with Marianne Compre, our other co-founder, chairs those meetings. And in one of those, we had the pleasure of having one of our next speakers, Delphine Pedeboy, as part of that. And it was in terms of female genital schisto and this kind of lived experience and the whole kind of advocacy arm of that. We were fascinated to find out that actually Delphine works with the company Dimagi, and they're involved in creating apps and having this entire mentoring and movement moving forward. So we wanted to have that as part of this session. So I'm honored to have both Delphine and Sarvesh on the actual presentation themselves. I think that's enough from me. I think I'd like to hand the floor over to both of you.
Thank you. Thanks, Cameron, for introducing me. So my name's Delphine. I work as a Senior Partnerships Manager at Dimagi. We're a health tech firm. We make tools for frontline health workers around the world. And we're the largest such tool in the world. We've had deployments at scale, at national level, which Sarvesh will tell you about. So Sarvesh is my colleague, also based out of South Africa, and he's heading up our innovation unit. But before we talk about that, I wanted to give you a bit more information about my experience with NTDs. Dr. Cameron, thank you for asking me to speak again. I've done a few speaking engagements on schistosomiasis in particular, as someone who's had it. So I'm always happy to share that experience in the hope of people finding out more about the disease. And also, I know all of you are probably familiar with schisto, but we'll talk about something that's a little bit more neglected now. And then this was just really to shed light on this issue. But I also do work at Dimagi developing tools for community health workers. And I thought it would be good to segue into that because we have done a lot of work in the NTD space and we wanted to share that with you. So My story is that in 2017, I contracted schistosomiasis on a work trip. It was in Malawi, which is a highly endemic area, as many of you know. And at the time, doctors didn't know exactly how to diagnose me. I was presenting with some reproductive health issues, and unfortunately, it was misdiagnosed for a long time as it presents. So the schistosomiasis does sometimes present as a reproductive health issue in women. And in fact, it's estimated that 57 million women and girls have active female genital schistosomiasis at the moment in the world, especially in sub-Saharan Africa. So it's a parasitic disease, as you know, and it's transmitted through the water snail, which hosts the parasite, and it then enters the human body. And what it can do is it can lead to significant organ damage over time. With women in particular, leads to fertility issues. And it can also, it does create lesions in the reproductive system, which then increases the chance of the patient contracting other infections such as HIV, for instance. So it's estimated that having female genital schistosomiasis, FGS, increases the chance of contracting HIV after exposure by a fourfold, which is huge. So this is a very little known fact, and it's something that's obviously of huge importance because of its co-infection risk. But as it stands, FGS has been, I would say it's doubly neglected disease because it is a form of schisto, but it's also a form of schisto that affects women, and it's surrounded by the same sorts of stigma that surround HIV or any kind of STI, even though it's not an STI. So there's a lot of issue around stigma with women not being able to have children. They obviously can't participate in the community or they can't fulfill their role as mothers, and this is having a big impact on their lives. And this has a knock-on effect on mental health. So there'll be an International Health Journal special this year on mental health stigma and NTDs, of which I'll be writing a piece sharing my experience with FGS. And then some of the key issues that came out of that. And so in parallel, I'm also working with Sarvesh at Dimagi, looking at how digital solutions can help these patients. And as I experienced the issue myself, so I started thinking about how we could use digital to help these issues. And some of the key issues I found with FGS, even as a patient who has access to healthcare and isn't living in a rural area, is that there's definitely a knowledge gap. So a lot of clinicians aren't aware that FGS exists. Community health workers don't know that it exists. This leads to misdiagnosis. So oftentimes this issue is diagnosed as something else. It's diagnosed either as a skin condition or it's diagnosed as an STI, which again, it isn't. The length of diagnosis is very long because there are clinicians don't know exactly what to test for, and also the availability of treatment is another issue. So praziquantel, which is the current treatment for schistosomiasis, is actually oftentimes not available, or it's not available in the communities that need it, and unfortunately, it isn't used as when a female patient presents with these kinds of symptoms. It's not something that is top of mind. It's, as I said, often mistaken for something else. So I just wanted to share this little snippet just to, first of all, shed light on FGS, because I always try and, Dr. Cameron, thank you for letting me speak on this, because the more people know about it, the better. And also just to raise some of the issues that are, that surrounded my diagnosis, but all the 57 million women that still have this issue. And I'll pass on now to Sarvesh, and Sarvesh is going to tell you about how we've been using community-based tools to help. Cameron.
Hello. We got you. You just froze there for a second. There might be a connection issue on yours, but it's fine now. It's fine now. Sorry. There we go. Yeah. So over to you. Yeah.
Okay. Thanks, Delphine. And hi, everyone. As Delphine was saying, my name is Sarvesh Tewari, and thank you so much for joining. I will be talking about some of our experiences developing and deploying these digital tools, specifically community-based digital tool for NTD management. And I currently head the innovation hub at Dimagi. Dimagi we have been around since 2002, and we work on different sectors. So health is one of those sectors. We are a B Corp certified company, deployed such community level solutions in more than 130 countries, working with frontline workers, a lot of frontline workers on different illnesses, different disease. And what we do is we have created this platform called ComCare. This platform is what is the underlying platform on which we build these Android-based applications. The platform works offline. It is multilingual. It is an open source platform, so anybody can use it and customize it for their need. And it includes a lot of multimedia. So what I'm going to do is, as we know, there are a lot of challenges when it comes to NTDs, and depending on the NTDs, we heard some of those in this session. But for example, when it comes to vector surveillance, lack of awareness among the high-risk population, or generally, like I think the program-related things. So what I'm going to focus on is I've picked up three challenges which we have worked on, and give a snippet of some of the solutions that we have created and how they have been able to, how we have been able to work with the community health worker in giving these apps to help with NTD management. So first challenge comes around vector surveillance and control. There are different kinds of programs or interventions that we have seen being deployed. For example, there is inability to find sufficient, for example, black fly is one of the key vector that transmits NTDs. So inability to find black flies for testing, and specifically these are very seasonal, and the whole maintenance and execution around finding those flies have been a challenge. Or when it comes to vector surveillance, lack of timely and relevant data for program managers or for governments to make decisions on what all activities needs to be done. From an epidemiological standpoint, there are limitations which with existing modeling efforts, and there are a few examples that if you can see, I've written down, which is like limited by tree canopy. So just to give some context for people who might not have not know about this. So one thing which comes up is when we are looking at the geospatial data. It depends a lot on the image resolution, and then it gets covered because of the trees, because of these vegetation. So when we look for, let's say, finding these vectors, be it mosquitoes, be it flies, different insects, it does not give us the right data points to model those for epidemiologists and then predict outbreaks or do collection for testing purposes. And then a lot of NTDs that we have seen work through campaign. So there are a lot of campaign-related challenges as well. And one thing I think which comes to my mind is, for example, scientists are, as far as I know, are also exploring ways to genetically alter the vector so that they cannot carry the parasite. The genetically altered vectors, the idea is that these altered vectors would then be released into the population to breed and spread their genetic abnormalities to the future generation. So kind of when we think of vector surveillance and control, that becomes one of the key interventions from an epidemiological standpoint. So this is one example from different apps that we have built on ComCare for vector surveillance and control. So we did one indoor residual spraying campaign. This was deployed in a lot of different countries. I think here it says 14, but I think we scaled it to 17 sub-Saharan countries. And it focuses on these spray personnel going door to door or community to community, using the tool to plan their campaign, use their spray, and then spray it in these sites during the outbreak season. And we worked up with a bunch of different partners. These became, in some countries, it also scaled to national scale. So this became one of the apps that was very effective in controlling the vector, like surveilling the vector, but also controlling the outbreak before the outbreak seasons. Then moving on, another challenge that we have seen comes up quite often is payment delays. So a lot of NTD, community level NTD work is done by community health workers or volunteers who go from community to community delivering these health services. And a lot, especially in the sub-Saharan Africa, what I've seen is a lot of these work gets done from a seasonal standpoint, which is that for a particular campaign. So if let's say you want to run a mass drug administration campaign in which we want to give preventative drugs to the at-risk population, be it pregnant women, be it children who are below a certain age, who are more at risk with these NTDs. The whole campaign requires a lot of planning, but one key component becomes that when the campaign is done, these health workers get paid for those campaign activities, and that is one key component in terms of what when we look at how we define the success of the campaign, especially coming like when the countries have to report to WHO in terms of controlling these or to different funding agencies for the success of a campaign. And so we did this for several campaigns in again, like I think this project was also deployed in 12 countries, 12 sub-Saharan African countries. And one challenge was when the campaign was done, the payment would take 90 days because of verification and all the other delays. So what we did is we built this application which can fast track some of those delays. And these delays were directly impacting the motivation level of the campaign workers, community health workers, and then also how many community health workers will end up showing for the next round of campaign was directly correlated. If folks are interested, I can also send some research which has been done around this, how this directly relates to it. I have included a WHO link as well on this slide, so happy to share that as well. And then the other challenge was in the whole payment process, because in Africa, the payments would be done through the mobile money providers. And when we think of NTD management or the programmatic delivery, especially at the community level, I think this is always seen as the financial component, which does not define directly what the success of the program would look like. But in this case, what we notice is that, as I said, like a lot of campaign workers were not showing up for the next campaign. So we know that there is an outbreak season coming up. We would want to go ahead and give these preventative medicines, but we don't have the staff or the workforce to be able to implement that program. And even once they get paid, the access in these rural areas to cash flow and bank account is really low. So they won't be able to use the money which has been paid to them. So what we did is we developed this very simple application in which a supervisor will enroll and verify the worker. They will keep the details, complete the know your customer form, which is required in a lot of these countries. The government mandate requires that. And then once that database is maintained, then the supervisor will assign them to different campaigns. So if let's say I am a health worker who is part of this campaign for the next outbreak season starting in April, my details exist, my bank account, all those details exist. It is verified with the mobile money provider. And then for my work assignment, I get assigned an area or a catchment area, and I can go ahead and then go door to door, screening patients, delivering services which are required. And then there was another component which was around attendance tracking, which generally just helped for training and making sure that the pay which is linked to the attendance is also digitized. So this was one application, and we have been implementing this for more than 3 years now. And we did an independent. So this is a project where we work with the Bill and Melinda Gates Foundation and the WHO Afro team. And the Bill and Melinda Gates Foundation also funded an independent study where we found out that the payment was fast-tracked, or the payment time was reduced from 90 days to 14 days. And what this did is that the workers would come for short campaigns, do the work, get verified, get paid, and then move on to whatever other jobs they are doing, and then join back in the next outbreak season. So this brought in a lot of efficiency in the overall campaign management. And then the final challenge that I want to talk about is the treatment coverage. So one thing which we have seen is, as Delphine was also mentioning, that the identification of these NTDs is not easy. And then once you identify who, diagnosis is one challenge, but even to diagnose, you need to identify those specific subgroups, whether it is preventative programs, or it is post, or it is treatment program. And so identification and targeting has been a challenge at the community level. Supply chain becomes again a key challenge, especially when it comes to medicine disbursement. When we think of facility-based interventions, even there, a lot of these areas are really remote. So if you see on the right, this is from one of the sites in Nigeria, where the health worker needs to go to really remote areas, and imagine a lot of these supply chain challenges do not, or these supply chain challenges prevent the health workers from delivering those medicines. So they will not have availability of medicine at the right time. They will not have proper access to those and storage facilities. So what we did is, this is again another project that we did with CDC Foundation in Haiti. And this was a mass drug administration campaign. In this, what we did, we built this application. The screenshot that you see on the right is the home screen for this application, where the health worker will go into the local community. They will track each household and everyone who is part of that household. So they will record the household, they will record the head of the household, they will record every member who is in the household. So kind of do a census, and then whoever would be eligible for that particular that particular MDA campaign, they will then show up in a different list. Then here, this also included components of malarial medications as well, because if you see at the community level, a lot of dengue, malaria, and chikungunya interventions are co-designed. Once they were identified, then the health worker could target those intervention or give those medicines in a targeted way, depending on the context of the patient. These are few screenshots from the same app. So this is just one workflow that I've included here, which was around enumeration and target identification. So the first step would be they would collect consent that they would want to be registered, then register household details, including the GPS coordinates. And what this GPS coordinate will do is, I'll show in a bit with some future work that we are doing. But right now what we have done is collecting these GPS coordinate and then using it to efficiently design what the service delivery would look like. So if there is one health worker, how can they effectively cover majority of the households or communities in the shortest possible time using the geo location that they have collected. And then they go on and have some individuals like household members registered and have those targeted interventions. So moving to the last part of my presentation. So when we think of what could be a future scope, or specifically when we look at the tech for NTDs, and especially where it can add value. So these are two examples that we have. One is that when we think of population estimates, we need those targeted interventions, identifying and targeting those beneficiaries for it. And having something like this on the right, on the left that you see, this is a heat map which you can zoom in and then you can target and say that, okay, this is where I'm seeing the most outbreak, or this is from the past where I've seen majority of the outbreaks in the past seasons. And so next effort by the government as well as the NGOs and INGOs can be put around that. On the right, you see a micro planning map, which is when this overlays different data. So for example, river data for especially river blindness, for example, land data, so vegetation data, all of that is overlaid onto the household GPS that we collected. And then the map can be used to give a path. So the way Google Maps work, that you give a location A to location B, it can give the shortest path to the health worker to cover all the 5 locations that they want to do. It can also say that, okay, maybe this is too much work for today and you only have 2 hours to complete this, so we can come back to this tomorrow. So it kind of helps in actually not only micro planning, but also implementing some of those features. And then finally, I think some of the innovative solutions that we have seen to work is, for example, having chatbots or SMS-based counseling and education for patients or people at risk, a case management system, as I showed, for identification and diagnosis, and specifically asking the right questions, following some of the checklists and protocols that the previous presenters have also talked about, modeling solutions to predict outbreaks from the previous data, and then kind of a dashboard to triangulate epidemiological data with not only zoonotic neglected diseases, because there is a lot of interaction between the zoonotic and the human flow of diseases and spread, but overlaying with rainfall and land use data. So I think that is where I'll end the presentation, and will be curious to see questions at the end. Thank you, everyone.
Thank you very, very much, both Delphine and Sarvesh there. What an amazing presentation. I think you covered all the bases in terms of what we were trying to achieve in that, from the advocacy. We knew that in any case, because Delphine had the previous session a while ago with Marianne, and it was very, very strong, because it's such a personal and such a heartfelt kind of position on FGS for you. We really felt that in that earlier session. So you've got that, but then this technical side of Dimagi in terms of the Sarvesh's input there as well, absolutely amazing. You've thrown up quite a few kind of avenues of thought that we can explore in the Q&A in terms of the future-facing scaling up this and the kind of role of certain, let's say, the youth in Africa, the digital kind of opportunities that exist. You've got those partnerships that you've explained already in place. Now, how do you scale that up? You know, all this kind of stuff, responsibilities in terms of data. Many, many years ago, people like Manju Rose Matthews from India saying, excellent, Sarvesh, well done. And a lot of kind of enthusiasm, I think, in terms of that particular presentation. Thank you very much. We're going to put some questions up for the end, for the Q&A, so you have to just bear with us, but we've got a lot of food for thought there, so thank you both very, very much for that. Brilliant. So thanks for that. That kind of brings us to what we wanted to do, our last speaker. You've seen the Skin NTD app with NTDs app with Dr. Jose Postigo. You've seen Dr. Colin Forsyth's treatment app with the iChagas app at the DNDi, and you've seen various approaches there that Dimagi have been involved in. For us, it's very interesting because many years ago, when NGOs were active, a lot of people would classify them as they would become the de facto repository for, let's say, longitudinal patient records in an area, right, or data sets attributable to one disease or one area just by being there. And that coupled against the lack of health system in that place or healthcare structure, they'd have the data. At the same time, you've got an increase now in, let's say, RDTs, or enhanced disease surveillance. So there's a lot of data about to start coming up. Yeah. In fact, I'd say this brilliant title that Professor Joacim has put together, this the oceans of data, right? So what do you do with that? So we wanted to have a look at that. And given the rise, we've had AI earlier in terms of the dengue avatar that Takeda have come up with to strike some kind of resonance across the ASEAN kind of landscape. Brilliant presentation, quite amazing use of AI. But we wanted to see, what does that mean for the data that's being generated through these apps? You know, we're talking about citizen science almost on steroids. You know, there's so much data about to come out. It's everywhere. It's not just, it's everywhere. So we want to have a look at this. So I think without further ado, I think we could pass the floor over to Professor, my great pleasure to welcome Professor Joacim Rocklöv from Heidelberg University. Beautiful Heidelberg. I've been, absolutely beautiful place. Love that place. Heidelberg Institute of Global Health. And so we're honored to have you here. And I'm going to hand the floor. Just before I do, I would say to the audience, have your questions. I know that Dr. Arabador has very kindly put in a very interesting question there, and also Dr. Manju Rose Matthews in terms of a couple of questions there. But there are other attendees there. Please don't be shy, because this is really about you. So you might as well get in there and get some questions in. Enough from me. The floor is yours. Joacim, over to you.
Thank you, Cameron, and thanks for inviting me to talk about this issue about, you know, how do we process and analyze data, and all the data, the different types of data that come available with all the new technologies and citizen science and so on. Yeah, so first of all, I'm sort of a in between global health epidemiology and computing science at Heidelberg University. And I work with computational methods. So I'll talk about and give some examples on how we process data, and how we also a little bit on how we collect new types of data and how we process that in using machine learning, which is a very powerful tool with a lot of different features and a lot of different ways we can use it. But I think most of you probably still don't really know exactly how to use it in different situations and what's good for different data types. So I wanted to just give a short introduction to that as well. There is a lot of talking around machine learning globally, and first of all, machine learning is a lot of different technologies and different algorithms of machine learning used for prediction, particularly, and in contrast to statistics, which is used for often causal inference, or trying to do a causal inference at least. Machine learning is more for prediction and to some extent also pattern recognition or dimensionality reduction if it's very large bioinformatics data, for example. And then in machine learning, there's a lot of different techniques. We talk about supervised learning, we talk about unsupervised learning. The difference is basically that in unsupervised learning, we're just looking at the patterns and sorting the data a little bit in different groups depending on its characteristics. And in supervised learning, we actually do classification, we have labels and can do classification and so on. So that's more towards what most of us probably have been working on, or you and are aware of in terms of regression and statistics, where we do a lot of this type of classification and regression tasks and so on. What's also really more of a revolutionary in machine learning techniques nowadays is also visual learning. And visual learning and visual predictions and image recognitions and so on is really where we have much better tools and techniques available today compared to in the past. We also have the natural language processing tools. Most of you see and use probably ChatGPT as one of them. It's very powerful, as you can see, and it's likely going to be quite useful in research and in global health and for NTDs in the future. We just need to figure out how we can best use it in what situations. Natural language processing can be used in many applications as well, I think. What's really key behind the machine learning and a key methodology is neural networks, which is behind some of the most promising and used techniques today, like visual learning or the natural language processing. But it's not the only one. There is also a lot of good prediction abilities in, for example, tree-based methods, where we have these type of decision trees, and we create forest of decision trees, either as independent trees and forest, or as sort of a sequence of trees where we get better prediction abilities depending on the task. But these are basically the main landscape and orientations of the predictive machine learning methodology that we have at hand today. Talking about the data, in one of the projects that I'm leading, ID Alert, we do data collection a little bit similar to what we've heard in the previous talks, using apps and novel ways of collecting data. And that's also very useful citizen science data, for example, which bridges this kind of gap between passive and active surveillance systems, for example. It might be selected, it might be unstructured, and we need to find ways to using this data with potential biases included. We also work a lot on the advanced analytical and predictive capacity, and that goes back to the previous slide where we have these type of different machine learning methodologies specifically that are good for different tasks. In the ID Alert project, we work on developing and using surveillance of smart traps. So we have smart traps with acoustic recognition. Using machine learning acoustic recognition, we could identify which mosquito is which female mosquito is which, and for example, classify and count the number and the abundance of Aedes albopictus. We could also use apps such as and do use apps such as the mosquito alert app for image classification of mosquitoes, and that's based on visual learning as well and neural networks. It can have quite good predictive accuracy, so it could save a lot of time from entomologists in actually classifying or barcoding mosquito species, and it could give us a completely new range of data, which we might not be able to, at least sustainably collect without this type of automatized collection and classification techniques. So that can be very useful. It's obviously calibrating and creating these type of classification, like the image recognition models. We need to have label data based on entomologist expertise into being sure about what mosquito species is actually which, and that's a little bit time consuming, but when it's up running and classification works, it saves a lot of time. So these are some of the new novel data streams that we are testing out and developing in the project at the moment. We also do a similar application for ticks, where we classify ticks using also image recognition and with different quite advanced machine learning methodologies and neural network approaches to do this classification, also processing of the image to find specific parts and zoom into different parts of the images in order to make that classification in a better way, and to remove a lot of noise from the images. And that's also a citizen science activity, like the mosquito alert, where citizens are engaged in sending their images and reports into, in this case, the Swedish Vet Institute, and which we then sort of analyze and provide data points of observations from. Natural language processing is a very sorry about the the slide is not very clear, but natural language processing is a very powerful method as well. And the difficulty with language is that it can mean a lot of different things depending on the context. We can say things in many different ways, and we have different grammar, but we could still have the same meaning and so on. So the methods need to be really quite smart in order to figure this out. But that's also something that's increasingly well functioning in using machine learning applications like the ChatGPT, but not only. And that could be also really useful in understanding both language, but also social media signals, for example, or conversations on vaccine hesitancy or on sentiments could be, of various types, which we can get information of. We've been working on social media signals for different sentiments in association with outbreak events, for example, and extreme events. And it's possible actually to use these type of natural language processing techniques to see how the sentiments in social media is actually changing, for example, positive, negative sentiments and so on. And there's much more one could do in this domain. There's also predictive models which are using our biological knowledge of how transmission occurs. For example, these type of SIR structured models which keep track on the number of infected, number of immunized, recovered, and the number of susceptibles in a population. This could be broken down into different demographic social groups and structures in society. In the past, there's been some parameter estimation done into these models, but there's a new development in machine learning, which is also providing ways to estimate parameters and parameter dependence on covariates into these type of structures which are kind of biological and population informed, which could give us more predictive models, but at the same time also which could help us make inference about parameters and transmission dynamics, R-naught values, and the factors that determine and make those transmission parameters vary over time. And that's also possible to do using neural network approaches, and a number of different prototype studies have been published in this domain. So that's also a very interesting way of doing predictions in this area of machine learning and infectious disease and NTDs. One method that I would also want to mention is the tree-based methodologies. The tree-based methodologies are these decision trees where you basically, in the simple case, you classify an outcome, for example, outbreak or no outbreak, or disease or no disease for an individual, based on features that you observe for that individual or that location. And then you train the tree and to do good classifications and predictions. In the tree-based methods in machine learning, you have forest of trees. And this has been a very successful area of application in machine learning, because it works really well to predict tabular data, so data that we usually have in Excel or in that type of data files in the long format or in the wide format. The tree-based methods have been developing over time, and one of the more advanced methods currently is XGBoost. It's an optimized gradient boosting methodology that's very efficiently runs on your computer using parallel processing. It has an efficient tree pruning to avoid overfitting, meaning that the trees are not grown too large, because then they usually doesn't work to, in external predictions on the data that's not been used for training. It handles missing values really well, and avoids overfitting and bias. So that's a really simple and good method. It's, for example, implemented in R using in the XGBoost package, and with also explanatory features, so you could also actually see what's behind these prediction and learn from the prediction what features, what variables are the most important, and in what way, and even also in what locations. So and XGBoost has been even outperforming other type of neural networks, for example, in this type of tabular data tasks. So again, it goes back to what some machine learning methods like neural networks, deep learning, convolutional neural networks, etc., are really good for image classifications. XGBoost and tree-based method really good for tabular data and predictions. RNNs, recursive neural networks, etc., and very, very good for time dependencies, etc. So you need to know, you need to apply different machine learning to different tasks in that sense. I wanted to give one example. I might be running out of time, but just shortly, we predicted the drivers of West Nile in Europe using bird migration data, mosquito data, and outbreak data for more than 10 years in these geographical locations. We used XGBoost. The study is published in Lancet Regional Health Europe, I think. And then we calibrated a model of XGBoost. We extracted we withheld some of the data from the feeding so we could really test the model. This is called cross-validation. We implemented the model in R. We also calibrated the parameters and came up with a quite stable model for the predictions. This is the 2018 distribution and all these distributions over the different years. The predictive ability of the model trained on data from 2010 to 2017 had an average area under the curve of 0.97, and when we tested that, there could maximally be 1. And when we tested that to the external data that was withheld, it had an ability of 0.93. So that means a sensitivity and specificity of predicting outbreak years and outbreak areas of about the same levels of 0.90 something. So that's really a high accuracy, and we used climatic data for these predictions as well as vectors and birds and vegetation index, etc., and socioeconomic data. What we found was that when if we observe the climatological data up to the second the first 6 months of the year, we can predict the rest of the year based on those observations with high accuracy. So that also holds promise for actually proactive actions and response. Using particularly climate information was really important in those. We could also predict the probability and how the probability of outbreak risk has changed over time in this region. Thank you. That was all for me.
Wow. Joacim, that was absolutely mental, basically. Absolutely brilliant. Absolutely brilliant. Thank you very, very much for that. Joacim, a lot of food for thought there. You mentioned this XBoost package. We had a session with Professor Paula Moraga, who I'm sure you know her. She wrote a couple of textbooks on R. We called it in R and Beyond. She's at KAUST at the moment. And that was about a year ago. I chaired that. It was a Connect session that we did. Absolutely fascinating how this is all evolving very quickly. And you're now mentioning packages like XBoost and all of this kind of enhancement of predictive capacity and what that's going to do to data. We could go on for hours. I'm telling you, we're going to have to bring everybody back. So firstly, thank you very much for that. There were questions that had come through, and I'm definitely going to ask them. And so Manju, Rose, Matthews, thank you very much. Unfortunately, I've just lost the other questions that I had seen them, so I had to refresh my page. For some reason, they dropped. So if I could ask Manju, and I think there was another question there. If you could just put that question up again, we'll bring that up in a minute. But if I could ask the other, if you don't mind, if that's okay, if I could ask the other panelists just to open their cameras and microphones. If it's okay, we could go until 3:30, so 15 minutes of quick questions, if that's okay with everybody. If you have to go, we did say 15, but we're kind of overrunning. Absolutely fine. If not, I'm just going to plow on till 3:30, if that's okay. Yeah? Okay, brilliant. So I think Dr. Postigo, if you're there, if you can put your camera on, brilliant. If not, then we'll just carry on. Oh, brilliant, you're there. Excellent. Excellent, so thank you. So I suppose bringing all these questions together, or just trying to have some kind of coherent question, and we haven't got that much time. Just coming back to the earlier presentation of Dr. Forsyth, Colin's presentation, and building on something that we'd heard earlier, obviously apps in a disease awareness setting or used initially to start building longitudinal patient record data or a picture of that disease in a community, right? And it gets to a point where that information is generated, it's there. The call to arms that then comes next, right? That's one thing. So a trigger, better diagnosis, informing certain, the trigger, that data then triggers a call to arms. What's your view on how that's going to change when you enhance predictive capacity? And I'm going to ask everybody that question. So starting with Colin first, because I haven't seen you since 2017. Go first. Okay.
Yeah, I think one of the main challenges with Chagas disease and other neglected diseases is just not only the neglect sort of in the health setting, but also in the information setting. So with Chagas disease, we're always working with uncertainties in the data. We're always basing our planning on estimates, and also the surveillance and the reporting is a major challenge right now. So I think maybe the future holds using apps or other mobile technologies. The hope is that would facilitate just being able to identify where the people are who have been diagnosed, because right now we just need to test more people.
Yeah.
But once we can do that, we know that a gap is going to emerge between the people who have a diagnosis and the people who need to get to treatment. And so having tools that can help us facilitate that information tracking is going to be really key to all the efforts that are going on across the world to try to improve availability of treatment for neglected diseases in primary health care.
Brilliant. So kind of an access kind of angle in terms of the next steps, improving the access, kind of redefining that kind of space via the app and the data. Very interesting. Putting that question to Delphine and to Sarvesh for a second. You're dealing with communities and you're dealing with a system there. You mentioned very robust partnerships at the CDC level and very in-depth, kind of fantastic. And at the same time, we've got this human side in terms of, not that you're not human, Sarvesh, but this human story side in terms of Delphine, a very personal FGS kind of thing. So the community kind of enhanced citizen science with this predictive capacity leading to different endpoints. What's your view on then what happens to those communities? How far are we going to take empowerment? And that's quite a big philosophical, I guess, question. That's what we're talking about here. So be honest, both of you, where are we going with this, with the community? Are we talking revolution, or what are we talking about here?
Thank you, Cameron. I'm going to answer from my grassroots perspective, and then Sarvesh might be able to answer from more of a high-level technical perspective. For me, I think it's a two-pronged approach. One is we need to use tools to help clinicians. So the WHO put out a guide on FGS, for instance, a handbook, atlas a little while ago, which was very helpful. And one of the resources that I found when I Googled my own symptoms, because none of the doctors knew what was wrong with me. So I was very happy to see that WHO document, which had been published, I think, in 2016, and I was diagnosed that same year. So I thought, you know, if this document hadn't been published, I probably wouldn't know what's wrong with me, which is, it's crazy to me that, you know, in the 21st century, this is still happening. But so number one is help clinicians have knowledge and also make informed decisions using technology, which is a brilliant tool for dissemination. And the second thing that I experienced was also extreme isolation. So when you have a disease that the clinicians don't know about, that I'm lucky, I'm educated, I have access to internet, so I was able to maybe eventually figure out. But the biggest problem for me was having a disease that affects the reproductive system. In a world where women don't even talk publicly about their periods, it's very difficult to talk about these things on forums and so on online. There are no forums about this online actually at all. And we've seen the internet has been an amazing tool for women to share their health concerns and find other women who are suffering with with other reproductive health conditions. The internet's been a good place for that. However, this isn't happening for things like FGS. Yes. So what I would like to see in future is tools that, for instance, one of my ideas was having in every rural clinic a QR code on the wall, and anyone with their simple Android phone could take a picture or somehow join a forum that could link patients together. So to this day, I've never met anyone out of 57 million or estimate, millions of women have this in the world. I have never met another patient. Despite being in this position I am of advocating and so on, I still haven't met anyone who's had this experience. So I've met one woman, but she's a professor at LSTM, so that doesn't count really. That is the second thing I think we should do. So one is educate clinicians, and number two is empower people like people who've had this disease and who're still suffering from chronic impacts or who actively have the infection, so we can help each other and also feel less isolated, because that's leading to a very huge burden of mental health problems and stigma. So stigma, isolation, and mental health is all grouped into one, and that is for me one of the things that I'd like to see fixed through the use of.
That's a fantastic answer, and that's kind of what we were looking for. Is this humanization of something that's, the data itself, the app itself is really human. It's an emotional reality that comes with it, and I think, as you said, touching into mental, absolutely vital. Love the QSR idea. Hopefully, anyone watching is going to get involved and get that off the ground. That is something that needs to happen. It's a brilliant idea, actually. So thank you for that. Sarvesh, from your technical perspective, I'm just going to bring in a question from Dr. Manju Rose Matthews into the mix as well, because it's kind of part of this, I guess. So that Dr. Manju Rose Matthews, who had asked some questions about a game that she developed in terms of the WHO earlier, but I've lost that thread on this chat box. It's gone, so I'm going blind here. But the pandemic has provided massive data to governments in ELMIC countries. these data need to be intelligently used, which is kind of what we're saying, right? That the endpoints are now shifting because of the predictive capacity. We're asking, this data needs to be more intelligently used. How best can we bridge the gap between conventional public health challenges, such as the ones that Delphine has highlighted there, this kind of lack of empathy, or whatever, cohesion between the patient, all of that, public health challenges, and the actual data scientists' expertise?
Sure. Thanks, Kramer, and thanks, Manju, for the question. So I think the question of data is a key challenge which keeps coming up, especially I think when we look at this kind of data that we collect. It is true that it is very sensitive. So there are few ways that first of all, we handle right now, and then there are a few other ways that we can, as a community, get better at. So one thing is, when we look at the data that we need for, let's say, doing all the work that we saw from the other presenters, right? So first of all, predicting anything for like outbreaks, you need massive amount of data. Now, in the past few years, we have seen with all the computing power and growth in terms of that, big data becoming such a big thing, ChatGPT was mentioned. So all of this has become possible because of the increase in computing power that we have. Now, when we look at that, the epidemiological part of the whole data management, that's one piece, which is, if let's say we have that power, we have funding, we can manage that. But then the other part is when we collect the personally identifiable information, specifically sensitive information that we want to, let's say the few examples that I used around MDA campaign. You need to give a medicine to a particular person. You need to know their name, address, their phone number, and through this, that data can be personally identifiable. I think the one way which we do is, first of all, wherever you are storing that data and the ownership should be with the community, and not just the community, but also in the local hands. So if, let's say, for various purposes, government in these countries, they have data localization laws, which means that any data that you collect for these communities has to be within the geographical boundary of that country. So that's one thing, to kind of have data there itself in the country, whether it is servers which are hosted by the government or by these communities. Now, when we look at, again, like coming back to the server point, like when we look at server, it becomes really costly to maintain these huge servers for all the data. So one thing which we also have been doing is that if any data does not help us in better decision making, let's not collect that. Which is that if, let's say, I know that I need to understand where these outbreaks can happen and predict those outbreaks, and if for that outbreak I don't need to know the name of the person, I don't need to collect that. So I can assign an ID to them, and that way at the source itself we don't collect that. So all the data concerns are there. And I think it is a healthy discussion or a debate that I have seen, which is, there is in fact a datafication of these things, and many times when we look at why we are collecting data, we forget that the purpose is not to collect data but to draw insights out of that data. And so I think that becomes a constant reminder to make sure that this tension between when we look at collect data and then use that data to drive these programmatic outcomes, that always remains in sync. It doesn't become collection of data for a particular funding reason or a particular program and so on. So I think there are some of these ways that I think we can make sure that this debate remains always a healthy debate, and this friction remains something more productive rather than just collecting data for the sake of data.
That's a superb answer. So a very well thought out answer. I appreciate that. Applying that, Jose, to your approach to a wide array of skin NTDs with stigmas and all sorts of kind of behavioral issues associated with them for the patient, sensitive. How do you feel? What kind of predictive capacity are you looking at? How are you looking to move into this with the app? Oh, your sound. Jose, yeah, you have to put your sound on the top. Sorry, yeah.
Yes,
There
yes.
we go. Yeah.
Well, at the moment, the app that I presented is mainly focusing frontline health workers who can also be community health workers in very remote places in Africa, and is meant to help them with the diagnosis of dermatological conditions. It's not meant to be something for self-diagnosis. I was 2 weeks ago in Côte d'Ivoire, in a very remote area in the northeast of the country, and I was amazed that there was electricity almost in every village, and almost every nurse had a mobile phone. But in the national surveillance system, what they report is skin disease. No, they had 6,000 skin diseases in a district. So, as our colleague Sarvesh was saying, well, if you have skin diseases, what do you do with that information? And unless there is more granular information, there is nothing that you can give back to that community to try to control or address certain pathologies. Now, when it comes also to what Delphine was saying, not thinking only of the health worker, but also the community, the patients. We are in discussions with an organization called Global Skin, that is a global alliance of patients organizations. There is a very strong one for Chagas. There is a strong one for leprosy. So maybe we can talk to Delphine and fill that gap, that need that she raised. So as WHO, we can maybe connect with these organizations where we bring that, not only the human part, but the end user, the patient.
Exactly.
I mean, in WHO, we do those guidelines that are mainly about the health system, the surveillance, but we forget the name and the family name of that person. I think we need to make that further step to reach those who are suffering. It doesn't mean we need to do it ourselves as WHO, but maybe we can help networking in that sense.
I think that's a brilliant answer, and I really hope that out of this, some kind of collaboration for Dimagi and WHO, DNDi, all of you, Joacim, all of you, something happens. Something should happen, because I feel it's the right thing. Just going to spin this round. We've got a couple of minutes just to ask Joacim this question. We've looked at that from an end user's perspective, right? And this that kind of predictive enhancement of their experience, bringing their issues in and helping them, all of that, right? Here's looking at it from a different perspective, right? You mentioned, Manji's actually asked a question, how XG Booster, this package you'd mentioned in R, can predict future floods, right? We had our own climate change 2-day meeting with the Wellcome Trust in November. It was very, very well received, and we were looking at all sorts of stuff in that. And she's asking about the level of accuracy. I just want to expand on that somewhat and then get into this accuracy thing. So we're talking about the end user. The youth in climate adverse areas, as it were. Let's say coastline of Africa. Let's say Southeast Asia, to some extent Latin America. The youth, what can they do in terms of these packages like XG Booster? Do you run mentoring programs? That is an untapped resource. We ran a hackathon ourselves for dengue about 8 years ago. We had £20,000 to give out. We were shocked, man. We were shocked that people from all over the world, coders, youth, suddenly coming out with mad apps. And so I'm just wondering, long question, but package XG Booster, do you run mentor programs for this end user, for this end affected youth? Joacim?
Yeah, definitely. I mean, that would be really interesting. I just came back from Philippines running a workshop. It was not for end users, but for public health people. And as one of the technologies that we trained and tested out was XGBoost. I think people are, I mean, you could do so much with these technologies overall if you get a grasp on how and where. And I think if people are a little bit afraid sometimes to actually dig into it. It's not as difficult always when, you know, it's well packaged and it can be easy to use if you just get this, you know, some good ideas on how. So definitely.
Yeah, I suppose I'm kind of mirroring something the World Bank had written a few years ago, is that the digital economy across Africa, that's in the African region at least, is the place to be looking at for growth. And I'm just wondering how this kind of thing, apps, you've all shown such tremendous application of an app in these settings, or the kind of potential that's out there. Digital, you know, how much would you go into mentoring? Would you kind of invest time as perhaps a university, as an organization, as a PDP, as the WHO in this space? Open question. No takers. Open question. There's a willingness, I take it. Yeah.
I mean, yeah.
No, okay, just to say that from WHO, our main role is really to be in touch with people like you, with the doers, with the experts. You know, we are a small team in WHO, we are a small team in Geneva, and I think this kind of meetings and this networking is what makes it possible for us to identify colleagues, experts, organizations, partners with whom we can do things. So to me, this is how we do it. We now know some organizations dealing with skin NTDs. It's a new team in WHO that was created in January 2020, in the middle of at the beginning of the pandemic. So that is the role, is to get to know you and to collaborate with you. Over to you.
Brilliant. That's fantastic. And I really genuinely hope you guys set some kind of task force up, or some kind of, there's got to be a collaboration here. I genuinely mean that, and all sorts of aspects of this, from DNDi's Chagas to Dimagi's approach to Professor, to Joacim's approach, and to, as Jose said, it's needed, right? So I really hope it happens. Genuinely, I really hope it happens. I'm being flashed over in terms of, I better get off this now because we've got about 5 minutes until the next session. I'm going to get in a lot of trouble if I'm already over. So before the hook comes and pulls me off stage, I'm going to have to ask permission to leave, and say thank you very much to all of you. And I really hope we have the chance to have a further session. We have Connect every week. We just did one with the Peruvian database for natural products in Canada, the UBC's drug discovery effort there. Thank you very, very much. So if that's okay with you, I'll have to call it a day, and I'll further on. Joacim, you mentioned you were in Sri Lanka. I know you'd seen Dr. Hasitha Tissera. Yeah, he's a very close friend of ours. And we've got actually the National Dengue Control Unit of Sri Lanka speaking in one of the sessions as well, actually. But so that's fantastic. You know, the recognition is more than deserved. Yeah, properly awesome. And thank you very, very much to the audience as well. Manju saying thanks, everybody saying thanks. I'm going to have to call that a day and run to the next session. So if you can, please join us for the final session. It's coming up at 1:45. I've got about 5. Yeah, so, yep. Sorry, everybody. Yeah, thanks a lot. Take care, everybody. All right. Thanks a lot. Take care. Take care.
Thank you, everyone.
Thanks,
Take
everyone.
care.
Bye-bye.
Take
Bye-bye.
care.
Bye.
Bye-bye.